Hello, everyone. Welcome to our Journal Club webinar. I'm so excited for this session because I think it's going to be really interesting to dive into the research around Sublocade, a journal club for clinicians. So our agenda today, our acknowledgement. So first to think about that I'm here in Vancouver and the BCCSU is here in Vancouver. So we're on the traditional territory of the Coast Salish peoples, including the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. And then we have probably people from all over BC and maybe beyond who are calling in. So just to take a moment to reflect about the homelands of the traditional peoples of where we each are. So we are going to talk through our learning objectives. We're going to talk through the research and then have some lively questions and discussion. I miss Journal Club. Like with COVID, I really miss Journal Club. It's been one of the things I miss. So let's all pretend that we're out for a lovely dinner at a nice restaurant and we have some meaty papers to talk through. And so I want this to be really informal. So you can use the question function to type your questions as we go, and we can have it be really conversational as we pick apart this research. So we have two wonderful presenters today, and then I'm acting as the moderator. So I'm Christy Sutherland. I'm a family doctor in the downtown east side. For my disclosures, I'm an employee at the BCCSU, and I'm a physician at the medical director of the Portland Hotel Society. And so those have influenced my practice, basically working in the downtown east side for my career. We have Dr. Paxton Buck, who is an internal medicine physician, a clinical assistant professor at UBC. And then Dr. Puya Azar, who is a psychiatrist, works in the complex pain and addiction service at VGH and at Foundry Inner City Youth Program. Do each of you want to speak to your disclosures? We just realized we hadn't put in a disclosure slide.
Sure. This is Paxton. I'm happy to thanks first off for the invitation to be here and for the introduction, Christy. My disclosures are few. I am also paid a small administrative salary from the BC Centre on Substance Use, and I receive research funding from the Michael Smith Foundation for Health Research outside of the scope of anything I'm going to talk about today.
Yeah, it's Puya Azar here. Thanks for the intro. No disclosures.
Great. So at the end of this session, we want to understand the real world data describing the longer term efficacy, adverse effects, and patient experience on Sublocade. We want to be able to make informed decisions as clinicians on which patients might benefit from remaining at this higher dose, the 300 milligrams ongoing, instead of stepping down. We want to learn from published clinical experiences with Sublocade at low barrier clinic and understand some alternative Sublocade induction approaches.
So maybe should I take it from here then, Christy?
Yeah, great.
Perfect. Okay, so we'll dive right into it because we have a lot of material we could talk about today. I guess just briefly from my perspective, from Puya's perspective, we're going to present some data from a number of papers on Sublocade today. This is not, necessarily a traditional journal club. I'm more than happy to really get into some methods if that's where everyone wants to take this discussion. But more than anything, I hope that we can kind of talk about some more recent evidence with Sublocade and how that might affect our practice and our decision making as we move forward with this new medication. So just to get everyone up to speed, obviously we're talking about Sublocade today, and I believe there was a question already about whether this was certified for CME, and the answer is no, because it is obviously heavily industry slanted, so there's no CME unfortunately available for this talk. Sublocade, as everyone on the call I'm sure knows, is an extended release formulation of buprenorphine, monthly abdominal subcutaneous injection. You can see here photos of the 300 milligram induction dose and the 100 milligram maintenance dose. And this has been available technically in Canada since last fall, although obviously has been rolled out much more in the last few weeks as we've had coverage available for us in BC. So just as again, to sort of set the table for our discussion, I'm going to briefly talk about a paper that we discussed in the first of our 3 sessions here. So our first session was outlining was an overview of Sublocade, and I briefly talked about this paper, which is a Lancet paper from 2019 that again it's I suppose sort of the landmark trial for Sublocade and kind of sets the table for a lot of the discussion we're going to have from here. So I'm just briefly going to summarize this again before we get into some of the newer literature. So this paper here by Hayt et al. in the Lancet was a randomized control trial, and it was a 3-armed randomized control trial with just over 500 people enrolled. The three arms that they included were Sublocade 300 milligram injections once monthly for 2 months, and then ongoing treatment with 300 milligrams monthly. There was Sublocade 300 milligrams once monthly for 2 months with a step down to 100 milligrams monthly, which is generally the recommended dose. And then there was also a placebo group. So just to be clear, there was no sublingual Suboxone treatment in this group. It was injections compared to placebo. And you can see here sort of the major takeaway figure from this presentation, or from this paper, is as seen below here, where you can see markers of abstinence. So their primary outcome in this paper was abstinence. And here you can see over time the different groups. The red is the 300 milligram maintenance group. The purple is the 100 milligram step down group, and the blue is the placebo group. And you can see no real significant difference between the 300 and 100 milligram group, but a very, very dramatic drop off very immediately in the group that was getting the placebo, and it's their abstinence.
I had a question about this, Paxton.
Sure,
How do
go
you
ahead.
think this passed ethics? Like, I was just baffled to see a placebo-controlled opiate use disorder trial in 2019.
That is such a good question, Christy, and it's obviously the thing that leaps off the page for everyone. It's really, the takeaway from this trial is not a shocker that some kind of medication outperforms zero medication. It really surprised me that this passed ethics. This was done a couple years ago, so it was at least the ethics submission for this would have been sort of pre-fentanyl in most of the U.S. So I suppose maybe the stakes were considered less high then in terms of the consequences of somebody falling off out. I think in addition to that, there's also this was done in the U.S. where some opinion, and this is maybe me editorializing, but some opinions around oat are a little bit different in the US, or a bit more varied. And I think it's definitely something that they try to address in the discussion of this trial, specifically as to why they chose this rather than a non-inferiority trial compared to sublingual Sublocade. Those arguments that they make don't really hold water to me. They talk about the risk of a new, minimizing the risk of exposure to new medication, or having the smallest number of people in the trial possible. But really, I think this trial was conceptualized, performed, written. It was completely run by Indivior. I think they really just are setting themselves up to have the most positive trial that they could. And that is kind of the lingering question after this is how do they really justify this, and probably more importantly, so what? So some medication outperforms nothing. Not a surprise, but we'd all wait for the comparison to sublingual treatment for sure.
Thank you.
Sorry, I'm muted. So just to summarize the takeaway messages for this trial then, because this does sort of lead into some of the other papers that we're talking about, is that Sublocade showed improved retention and abstinent rates compared to placebo. Again, I don't think a particularly surprising finding. Maybe more interestingly, there was no real difference noted in this trial, in a 6-month trial, in retention or abstinent rates between Sublocade treatment groups. So that's between those that remained at 300 milligrams versus those that stepped down to 100 milligrams. And lastly, the side effect profiles that they reported, again, sublingual buprenorphine was not included in this trial, but comparing rough numbers, the side effect profiles were very similar to what you'd expect with sublingual buprenorphine, with the exception of injection site reactions. So those are most commonly pruritus, pain, or erythema, and between 5 to 10% of people reported some sort of a side effect of the injections relating to injection site side effects. And again, you can see the asterisks here. I want to emphasize this: Indivior was very involved in every aspect of writing and performing and analyzing this study. So I think that's something that's important to keep in mind. So any other questions there before we move on to the papers we're going to be talking about?
Oh, we're good.
Okay, so moving on to the first paper of today then, that I'm going to present, and so Puya and I will kind of move back and forth and tag team. This is a paper that's hot off the presses in the Journal of Clinical Psychopharmacology. It was actually just published this very month, so fresh literature. And this is entitled Treating Opioid Use Disorder with a Monthly Subcutaneous Buprenorphine Depot Injection, a 12-month Safety, Tolerability, and Efficacy Analysis. So this is really the sequel to the trial the Lancet trial that I just described. This is the continuation of that trial, which is why it was important just to touch on that briefly first. So this trial was an open label multi-center study, and the study design is an interesting one. It's a little bit complicated, but essentially what they've done was taken patients from the original Lancet trial. So again, that was a 6-month trial. So anyone who participated in that trial was invited to carry on into this open label trial for another 6 months. They also enrolled another 412 de novo patients, so patients who funneled straight into this open label trial. So you have 250 people who did a 6-month, very controlled trial where they're randomized to and blinded, and they then moved forward onto an open label study with some flexibility, and 400 patients who did a full 12 months the entire time with flexibility in the dosing and an awareness of what they were getting. So patients were induced onto Sublocade. They're first started on sublingual Sublocade, stabilized on a dose for 7 days, and transitioned onto the injection. And they were followed then for 48 weeks, for almost a year. Patients that were included those with a moderate to severe opioid use disorder, no other moderate to severe substance use disorders, and that's an important caveat for a number of the papers we're going to talk about today. And any history of suicidal ideation was also an exclusion factor. So again, just to be very clear, about a third of these patients carried on from the original Lancet trial for an extra 6 months beyond those original quite rigid 6 months, and 2/3 of the patients the whole way through were on this open label trial. Again, I'll point out that Indivior was heavily involved in the conceptualization and conduct of this trial. So who did they include in this trial? 2/3 of the patients were male, roughly. About 70% of them were white, and just under half of them had a history of injection opioids. So a small majority took their opioids either orally or insufflated or smoked them. Their retention rates over the 12 months of the study across all groups were approximately 60%. And of those retained, 60% of them actually remained on 300 milligram injections throughout the duration of the study, which I found really interesting because as suggested in the first trial, there was no real difference between 300 and 100. And yet in this trial, where it was open to patient and physician discretion, more than half of them remained on 300 milligram injections throughout. Between 53 to 74% of patients had some form of adverse event during the trial, and that's across all of the different groups, but those were mostly mild to moderate, and the most common ones are not particularly surprising. Constipation, injection site pain and erythema, some nausea or headaches, some insomnia. Nasopharyngitis is something interesting that continuously pops up. Actual discontinuations due to adverse events were very low, so less than 4% across all the groups actually stopped the trial because of adverse events, which I found quite reassuring as a prescriber. And we'll circle back to this, but 6 people in total, so 6 out of about 500 people, discontinued due to an elevation in their hepatic enzymes. So just to get to a couple of the results here, this is a Kaplan-Meier curve looking at study retention. So this is looking at all 4 groups in this trial, or in these sort of twin trials, and how they were retained. So you can see the x-axis here is days on study, and you can see this line right in the middle, which signifies that transition from the previous RCT into the open label trial. So the green bar, the lime green bar, were the ones that throughout were induced on 300 milligrams and had that flexibility in their dosing throughout the duration of the year. Purple were those who were initiated on 300, stepped down to 100 milligrams for the majority of the first 6 months, and then had flexibility in the second half of the year. The orange one are those that remained at 300 milligrams throughout the first 6 months and then had flexible dosing for the end of the year. And placebo, you can see, is here in blue. And placebo, in this particular figure, they cut off at 6 months because there's no further placebo treatment beyond that. Takeaway here is that retention in all 3 of these groups was pretty comparable. There was no significant difference in any groups. And again, as I mentioned, the retention was about 60% across all groups. So I find that, especially considering that the open label nature of the trial, to be fairly good retention. I'll just so there's one other figure from this paper then, and so this is the actual outcome. This is percentages of those who remained in the trial who were abstinent. And again, I'll say that just to be clear, this is for those that remained in the trial, their abstinence numbers. So this is not amongst necessarily all comers. This is an available data model, so all those who dropped out were no longer included here. But you can see for those who remained in the trial, that pretty soon after induction, their abstinence rates were fluctuating between 50 to 60%, and that was fairly consistent throughout. There's a small upward slope towards increasing levels of abstinence you can see over the year. I wonder, as a bit of a skeptic, how much of that has to do with people dropping out and who are less likely to have abstinence, rather than sort of increasing levels of abstinence amongst all patients throughout the trial. But still, overall, again, 60% of people retained, 60 to 70% abstinence amongst those retained. Pretty reasonable numbers, I think, to me. And the second half of the year, these retention and abstinence numbers are pretty comparable with those in the original Lancet paper, that original RCT. The last thing that I'll point out from this trial before handing it over to Puya is very specifically, they commented on injection site adverse events, because that is something that kind of continuously comes up around this medication. And I think that providers we talk about quite often, it is something that some people find quite uncomfortable, the injection. And you can just see here, this was subjective pain scoring. And you can see that the blue line in this figure represents the first injection, and the orange line represents the 12th injection of the year. And this is people's reports of how uncomfortable it was. And you can see that it does seem as if over time, the amount of pain reported is less. Again, take this with a grain of salt, because this only includes those who made it to injection 12. So those who found injection 1 to be particularly painful may have dropped out along the way. But it does suggest that as time goes on, people find their injections less and less intolerable. And the last piece that I'll point out here is that, and again, the key here is that this is among patients who were retained to the end. Over 80% of them reported that they're satisfied, very satisfied, or extremely satisfied with the treatment on this medication. So some asterisk to all of this, and that this is only mostly speaking about patients who've actually made it through the 12 months and were retained, but pretty supportive data here, I think, at that point, that people tend to have a good experience on this medication who stay on it. So I'll pause there for any questions about this trial, and we can always circle back to discuss any of these as time goes on. But anything anyone wanted to ask and specifically about this right now before we move on to the next paper that Puya is going to present?
We don't have any specific questions popping up.
Wonderful.
Oh,
Hopefully
there we
this
go.
leaves us.
Laura, how long do the adverse effects last?
Great question. So they've lumped all of that's hard to answer. They've lumped all. I've given you a summation of all adverse events. So that's every different kind of event, and that is not necessarily with the first dose. That's at any point throughout the study. So adverse events that are reported aren't even necessarily associated with the study medication. So I don't think we can say from this trial at all. I don't think we can give you an answer for that. The closest thing we can give in terms of would be this figure I'm showing you right here, which is strictly around injection site pain. And there you can see that people report some level of pain at the time of injection, which tends to fade by about 20 to 30 minutes. For every other adverse effect shown there, you can refer back to the paper for a breakdown of percentages of each of the very specific adverse events reported, but they can occur at any point during the trial, and oftentimes aren't actually necessarily associated with the medication itself. So for instance, the only death that happened in this trial amongst any participant was actually a gunshot wound. So that's reported as an adverse event, but presumably not related to the Sublocade.
But I guess we don't know enough yet to say, like, if someone has nausea that first month, to say, why don't we push through and see if it resolves in the next month?
Yeah, certainly from this trial, you can't say that. We at the end, we can talk about our collective clinical experience with the medication, and if anyone has a sense of that. I can tell you that I haven't done a lot of these injections, but in the few that I've done, there hasn't really been any adverse events reported other than the injection site pain yet. But my personal numbers are still quite low. So anyone else on the call who's done a number of these may be able to comment on that as well.
We also have another question about how do they define abstinence?
Great question. Two different definitions used. There was one definition which was just the absence of any opioid on a combination of urine drug screen and a timeline follow back interview. That's the one that I've demonstrated here. They also have set a bar of 80% abstinence over the past, I can't remember how many weeks at the end of the trial was a sort of a key secondary outcome. But the one that I reported there was just any illicit opioids in a urine drug a combination of urine drug screen or timeline follow back interview.
Great, thanks, Paxton.
A fairly strict definition of abstinence and a fairly conservative primary outcome, I think.
Mm-hmm.
Okay, with that, I will pass it over to Puya to talk about the next trial, which also builds off of the same study.
Thanks, Jackson. So this is interesting for me, particularly as a psychiatrist, because it looks at beyond what might be obvious in a placebo-controlled study when that looks at OAT. When you're comparing OAT to placebo, and as weird as that sounds, going back to Christy's comment, our expectation is that we're going to have higher percentage of abstinence, reduced cravings, withdrawal, etc., reduced use. But some of the questions that are interesting for me are that how is this actually impacting the individual's life? Are they having an increased quality of life because of their reduced use? As an addiction physician, I don't have a moral opposition to intoxication. And then sometimes we just assume that, okay, this study showed that there was decreased use, then therefore decreased intoxication results in increased quality of life. But what was interesting is that this study actually tried to look a little bit around patient-centered outcomes and quality of life. Next slide, please. So the goal was to assess the effects of buprenorphine extended release for opioid use disorder compared to placebo on patient-centered outcomes, measuring meaningful life change. So 24-week regimen, so fairly long, in participants with moderate to severe opioid use disorder. And again, 3-arm study, so interesting that they compared buprenorphine 300 and 100 versus 300 and maintenance on 300, and then of course placebo. Next slide. So they used a variety of scales, which I'm not going to get into any of the details, but basically what we're looking at is health status, quality of life related to health status, medication satisfaction, employment and health insurance status. And in the US, I used to live in the US, and health insurance status is interesting because it's irrelevant here in Canada, but in the US, it is an important measure of quality of life. And then healthcare resource utilization. So how often are patients going to the emergency room, et cetera, et cetera. So next slide. So compared to placebo, it was interesting that the patients reported better health, increased employment, decreased healthcare utilization, and increased medication satisfaction. So that's encouraging, and intuitively is what we would expect on an extended release opioid agonist therapy treatment. But also, maybe even more interestingly, Paxton, next slide. When you're comparing 300 with 300 milligram maintenance versus 300 and 100 milligram maintenance, certainly they again showed a significant improvement in this slide in terms of employment. However, there was not a significant difference between the maintenance on 300 versus maintenance on 100 milligrams. Next slide. So similarly, when it comes to health insurance, again, significant difference between treatment and placebo, but not a significant difference between maintenance on 300 versus 100. So, okay, next slide, Paxton. And this one was a little bit counterintuitive for me, just based on serum levels that you might achieve on 300 maintenance versus 100 maintenance. I would expect that perhaps there would be improved or increased patient satisfaction on maintenance with 300 versus 100. But this slide again showed the same thing, same pattern, that SURE versus placebo treatment arms had much higher patient satisfaction, but not a real significant difference between maintenance on 100 versus 300 milligrams. Now, this was not done in a population that uses illicit fentanyl. And I do wonder, we'll get to this a little bit in one of the subsequent papers about the difference in maintaining on 300 in a population that uses a more potent full agonist as their substance of use. So I think that's it for my slides for this paper. Went through pretty quick. Any questions before we move on to the next one?
More of a, this is Paxton, I have more of a comment than a question. Is I think it's really encouraging to see this paper come out as sort of a twin to that original Lancet paper, because I think this is actually very novel, looking at these kind of patient-centered outcomes for a new medication. And I think it's part of a movement that we're starting to see in the research, in the addiction medicine research world, is actually broadening our goals, aside from looking at strictly abstinence as our only outcome for trials, and actually starting to ask, like, what matters to people, and what other clinically relevant outcomes are there. So I'm just really, I found this really exciting to see this, because I honestly can't recall ever seeing a paper like this, at least of this magnitude, looking at these kind of outcomes.
Yeah, I totally agree. Now, I used to do some cancer research back in the day, and again, like, we would have these studies where there's a new medication that would increase lifespan by a certain amount. But when you looked at the adverse effects, quality of life may have been significantly less. And I always wondered, like, why can't we also look at quality of life as an endpoint? So it's particularly relevant in this population.
Great, and we don't have any questions from the group.
Okay, with that then, this Puya has lined up the next paper quite nicely. So just to recap, so where we're at so far, again, all this data coming out of this one fairly large set of studies, but amongst patients who are retained, fairly good response in terms of abstinence, fairly good overall happiness with their treatment as a whole, and we have objective markers here of improved quality of life in a variety of different domains. But the theme here consistently has been no real difference between the 300 maintenance group versus the step down to 100 milligrams in terms of any outcomes we've seen thus far. But as Puya pointed out, this is not done. This trial is not done in a population that uses large amounts of fentanyl. At least we're not as reported. So the next study that I'm going to talk about is actually not yet published, but this was a poster from last year at the American Society of Addiction Medicine conference. And this poster I found very, I think this meant a lot to me. Specifically looking at the population that I tend to treat. So this was also, again, based off of this sort of large set of studies that we've already described. And, I think already there we've identified one issue with the Sublocade literature. There's not much of it, and most of it does come from this very large set of papers that have been put together by Indivior, but I think they're still worth exploring. This poster is looking specifically at the response to 300 versus 100 milligram in the initial trial in the subpopulation that report in a history of injection drug use. So we're not able to quantify how much opioids people are using, and as Puya already mentioned, we don't know whether anyone's using, sort of ultra potent synthetic opioids in this trial. But they did look at this subgroup that may have higher opioid requirements, that being people who inject drugs, and asked in that population, is there a difference in the response between the 300 milligram maintenance versus the step down to 100 milligrams? So the methods here, so this is a post-hoc analysis. So they've taken the data from that original, the two first trials that I presented, the Haid et al. Lancet trial and the Andorran trial, and they've done a subgroup analysis after the fact on the population specifically who had reports of injecting drugs. So what they've done then, so they've taken the group who inject drugs and as one group and those with no report of injection drugs. And rather than compare those directly, they've used a technique here called propensity score matching to kind of balance the groups. So I don't want to get into the details of this too much, although again, if there are questions, I'm more than happy to talk about this further. But just for the audience here, if you've never heard of this tool before, propensity score matching is a really, really helpful statistical technique for observational trials to try and balance two groups that may not be balanced from the start. So what you're looking at is all the variety of variables that you have measured for each group and how those variables may influence somebody's risk of the primary outcome to be higher or lower, and then weighting the individual participants based on their overall risk of the primary outcome based on all of their individual demographics. So it's a way of sort of balancing out. So you assign propensities to each of the patients based on based on all of their variables, and each participant is then given a certain amount of weight based on their propensity for the outcome to kind of balance the two groups. So they've used this tool to balance those who inject drugs versus those who don't inject drugs, and then they've performed a multivariable regression or a statistical model that used to identify populations that may benefit, or to identify those who populations who may benefit remaining at a higher dose. So this is really the major takeaway figure from this poster. I've zoomed in here and I'll walk you through this. So if we look to the far, I don't know if you guys can see my cursor, but if we look to the far left here, we see the unadjusted model. So this is without propensity score matching. So this is comparing on the left here, people who inject drugs, and on the right, those who have no history of injection drugs. The light blue color is those that step down to 100, and the dark blue is those who remain at 300. So you see here in the unadjusted model, there actually is on this axis here is as abstinence on the y-axis. So in the unadjusted model, there is a difference between those who inject drugs versus those who don't inject drugs in terms of showing what may be a superior response to maintaining on 300 milligrams. So that's all well and good. And what they've done then, if we look in the middle panel, is here and they've actually risk adjusted. So they've done the propensity score matching to see whether that is due to the patient factors themselves or to bias that was introduced into this trial. And you see here that even when they use this statistical method to balance those risks, you still see in the injection drug use category a statistically significant improvement in abstinence rates between at 300 versus 100 in those who inject drugs. And if you look at those who don't inject drugs, that difference disappears, suggesting so that here in those that you when you've done a risk adjustment, those who inject drugs seem to have higher rates of abstinence if you maintain them at 300 milligrams versus dropping down to 100 milligrams, and that's only in those with a history of injection use. On the far right here, we've actually looked at those who use daily injected drugs, and you see a very similar thing here. So you see a borderline significant. The p-value here is actually 0.051. So if I'm going to be pedantic about it, you may say that's not significant, but you see a very similar trend where those who inject drugs seem to respond better to remaining at a 300 milligram dose, and those who don't have a history of daily injection drug use, there's no real difference between staying at 300 or dropping down to 100. So I think this, to me, is a really helpful poster to keep in mind when I am trying to make that clinical decision with the patient, whether to maintain them at 100 milligrams or a 300 milligrams, I should say, versus dropping down to 100 milligrams after the first two injections. The one other figure that I'll show from this is just, again, this is the full year's worth of data. So this is a figure you've already seen in that, where the first half before the line here signifies the randomized control trial, and the second half after the line is the open label trial. And if you recall, and this is amongst people who inject drugs specifically. You can see here at 6 months, The light blue line here is those who've dropped down to 100 milligrams, and the dark blue line is those who remain at 300 milligrams. So at 6 months, when you're looking at just those with a history of injection drug use, there certainly looks to be a gap here between those who inject versus those who don't, or sorry, between those at 300 versus 100. And once they transition into the open label trial, where it's up to the patient and clinician's discretion whether they want to jump back to 300 or stay at 100, that difference disappears by the end of the year. So I think this is really helpful for me to keep in mind when I'm making that decision around possible step downs with a patient. So any questions about this trial?
Yeah, we have a question about overall for this research. If you have more details thinking about applying it to our patient population here in BC for the various practices that people have for housing, employment, and gender and ethnicity.
So I can there's definitely more demographic variables out there. I'm not sure whether I can't remember if employed's on the list. I don't think housed is on the list. I believe you guys can see my screen, so I can pull up our table 1 right here if we want to get into it. Here is table 1 from this initial trial. So you can see a lot of details here. We have there's a fairly high rates of concurrent alcohol use. This is all their history of drug use. Comorbidities, we do not have those demographic variables reported here, at least. Just knowing what I know about there's a number of exclusion criteria for this trial. It's a fairly highly selected population. I suspect very strongly that that these are all people with relative social stability in their lives. I can't say that based on this figure itself, but that is an excellent question, though, because that really transitions quite well into the next study, which
Well, I was
is
going
going
to
to
ask
talk
a
about some.
follow-up to that one about participant recruitment. So they were just wondering about how the participants came to be recruited to the study. Like, was it from treatment centers or people who were interested in getting treatment, or was it from a more general people who use drugs population?
The recruitment here was that's a great question. So they're recruited from treatment centers in the U.S., from 36 treatment centers in the U.S.
That's so interesting. And then another question, given the post hoc nature, would you interpret this as worth trying out the 100 for IV drug users, or would you counsel your IV drug using patients to just stay at the 300?
So I mean, it's a great question, and you're right. This is a post hoc subgroup analysis, so of a trial that we already talked about some of the issues why you need to kind of take this all with a grain of salt. So I can't answer that question for you. And if you recall, going back to the one thing I found interesting is that despite not a lot of difference ever being shown on paper between these two groups, in the flexible portion of that first paper that I presented, I was surprised at how many people actually remain on 300 milligrams despite the supposed data showing no real difference there. So again, the next poster we're going to talk about, which describes some real world experience, may offer you a little bit more insight there. But I think this is mostly going to be it's going to really come down to a conversation with you and your patient. I think from this, I think a history of injection drug use will flag in my mind as one thing that might suggest that I may consider keeping somebody on a higher dose. This goes outside of any of the data we're talking about here, but just in terms of kind of other information you may use to make that distinction. We don't talk about the dose of bupe that anyone stabilized in this trial, but we do have data in terms of sort of average serum levels that are achieved with Sublocade and with various doses of sublingual Suboxone. So certainly anyone who's got a history of injection drugs or requiring stabilization at a higher dose of bupe, like anything greater than 24 milligrams, I would strongly consider keeping them at 300 milligrams empirically. But it also depends on how well they're tolerating it. So I didn't get into this, but there's slightly more adverse reactions, it seems, in the group that remains at 300 milligrams, which is not, I don't think, a huge surprise. So that's going to have to be weighed into it as well. And I think you're going to make that decision with your patient. And it's not a decision you necessarily have to make once and then abide by indefinitely. you're welcome to stay at 300 for as long as you want. That is certainly, there's good safety data for that, I think. But if you do drop down to 100 and cravings do return, there's no reason you can't back up to 300 for subsequent doses. So
Yeah, that's great.
it's going to be a good, there's going to be a lot of learning here, I think, among us in terms of how we our feel for this medication and who tends to
I bet
do
it's really
better with.
anxious. Like it's probably anxiety for patients to go from 300 to 100 milligrams. Sounds like a big leap.
It's possible. Maybe something anxious. You can draw out serum levels, and if that helps anyone, I think some people are going to be excited about it because one of the things we haven't really discussed on today's talk, but the 300 milligrams dose is 1.5 mLs, and the 100 is only 0.5 ml. So for somebody who finds the injection itself to be quite uncomfortable, certainly that's going to reduce the injection discomfort because you've got only a third of the volume. So some people may look forward to dropping
That's a
down.
good point.
There's a lot of factors at play here.
I have another question here about urine drug tests. Were missed urine drug tests interpreted as restarting drug use?
So I believe most of these data here, they've only used an available data model. So it's sort of skewing towards making things look a bit better than they might look otherwise. I should say that if they don't have a urine drug screen, but they do have the timeline follow back, the interview, then they use that data as well. It's a combination of the urine and the interview. So if somebody was not seen for a month, but then actually, truthfully, if somebody was not seen for a month and then it would be hard for them to return another month later because they would already kind of be off the medication, found their way out of the trial. You have to actually present for your injection. So I imagine, I don't know what percentage of them they don't have that information for. I suspect based on the trial design to be a small number. But you're right that they have not used any imputation or assumption that those are positive. Once somebody's dropped out of the trial, they've just dropped them. So that is sort of, I think a bit of trickery, you could say, by Indivior just to try and make these results look as good as possible.
And
As
another
far as this
interesting
subgroup,
question. Oh,
sorry, go
yeah,
ahead.
sorry. Well,
I
I
was just
just
saying, as
want to
far as
get through these
this, yeah,
questions.
go
Yeah.
ahead.
Well, so I think this is such an interesting question because of the long duration of action of the drug, would you expect the tail of the 300 milligrams to last for longer? So even in those first months of down at 100 milligrams, would we still be seeing benefit from the 300 milligrams loading?
Sorry, let me understand this question.
So like looking at abstinence in the first few months on 100 milligrams where people did just as well, could it be that since they had those 300 milligrams to start with, that 300 milligrams is still providing them protection, but if we kept them on 100 milligrams for 12 months, that we would start to see that abstinence go down?
So that's a complicated question. I mean, so all of these people have been started at 300, and it's a question of whether they're stepped down on 100 or not. I can show you again. We have a figure here of average serum levels for these patients, and where is it? That's here. So here's a figure. If you can see, you guys can all see my screen, I think, of average serum levels. So you can see panel. This is 300 ongoing 300 milligram doses, and this is 300 at the 100 milligrams. So in either case, you reach a steady state eventually. So the 300 and 100 milligrams, you do sort of you reach a steady state much quicker. With ongoing 300 dosing, you're continuing to climb. Right up to six. It takes right up to 6 months to start to achieve what looks to be sort of a steady state there. So I think that as to your time on 300, considering this data, half the data I've showed you is only out at this point. They still are just sort of approaching that steady state at that point. Which may demonstrate why there's some better effect later on. I think these are helpful things to keep in mind. Again, when you're counseling individual patients and when you're considering, potentially jumping back and forth between 3 and 100, lots of people, it's not uncommon, as you see in the next trial, for people to drop down to 100 milligrams and then re-up back to 300 milligrams, or even supplement themselves with some sublingual buprenorphine somewhere along the way. And that's something that Puyo will talk about in the next abstract.
Yeah,
Or
I
in the
was
next
just thinking
poster
about that
present.
question too. We might know the answer 2 years from now when there's cohort data about
Yeah, it's going to be
medication.
very interesting when you to get some real world observational data that's not done by Indivior on these medications, and sort of to verify some of these numbers. Because certainly, you know, all of this is quite heavily industry sponsored, and it's been shown, it's been the data is being presented in a way that looks pretty favorable. So you're right that in the next year to 2 years, it'll be interesting to see what else we learn.
Yeah. Okay, those are our questions.
Um, there's a couple other questions, but I'll go to Pua's next poster because it may answer some of these questions already.
Oh, okay. Maybe you're seeing questions that I'm not seeing.
I see two more questions that just popped up here around PRN doses. Both of
I
them,
think you can.
both. Hmm?
Well, I don't see them on my question. So let's do the last trial since it's about PRN
Sure.
dosing a little bit, isn't it?
Yeah, Puya, take it away.
Yeah, thanks, Paxton. So I found this interesting. This is another abstract and poster that was presented at ASAM, and I think it won an award there as well. And you know, again, like, I don't want this to be an industry bashing session, but you know, like when industry sponsors a study, and you know, you may be choosing a population, patient populations that you think are going to do best in this study. So it's always interesting to think about, you know, what about real world use of this medication? And this is what this poster attempted to present. And what they did was a retrospective case series of 40 patients out of their clinic in Boston. Next slide. Yeah, so, you know, oftentimes when I look at a study or a medication, I wonder about, will this apply to my patient population? And with regards, specifically with regards to demographics, you know, was this studied in a very well organized, high social economic status population, or can it be applied to some of my folks who may be struggling with homelessness or being precariously housed, etc.? Medical comorbidities might be interesting to look at as well, particularly hepatic impairment and Hep C, comorbid Hep C. Psychiatric comorbidities are also very important for me, particularly, you know, given that I'm a psychiatrist. I wonder about that interplay between psychiatric symptoms and their patient substance use. And also, very importantly, is the specific substance use, as we've alluded to previously. You know, specifically, you know, diacetylmorphine, heroin versus fentanyl analogs. And clinically, I certainly have noticed a difference in terms of response to opiate agonist therapy over the years, moving from primarily the heroin to fentanyl use. Next slide. So what this study went out to show was, you know, okay, fair enough, extended release buprenorphine may increase medication adherence and improve outcomes, but what about some of the specific challenges that you may experience in your high-risk population? And a couple of the challenges that they pointed out specifically, one was the need to stabilize patients on sublingual buprenorphine for 7 days prior to the induction of extended release buprenorphine. You know, this can get challenging, you know, given, again, sometimes the chaotic or impulsive nature of our patients and their circumstance. You know, medication non-compliance can be an issue. So patients can potentially fall off of sublingual buprenorphine within the 7 days that they have to wait to receive the extended release buprenorphine. And I certainly have had that experience myself. And the other thing they wanted to look at was, what about ongoing cravings and withdrawal experience while patients are on the extended release buprenorphine? Next slide. So here's some tables from their poster. So when you look at the demographics, yeah, it was a diverse population. You know, unstably housed was 77.5% of the folks. Psychiatric comorbidity was 92.5%. Chronic pain, 22.5%. Interestingly, you know, combination heroin and fentanyl was 97.5%. And polysubstance use with cocaine, methamphetamines, benzodiazepines, etc. And if you look at the slide or the table next to this one, so it was interesting that there was, in their baseline toxicology, they did find fentanyl for the patients, and also other substances as well. And the next graphic down in the yellow, that's interesting because it shows the number of days stabilized on sublingual buprenorphine prior to induction of the extended release depot. So you can see that where it says 0 to 7 days, you had 10 patients who were on buprenorphine for less than the 7 days that's indicated by the package insert for extended release buprenorphine. So meaning that they went on to show that they were able to induce people onto extended release buprenorphine in short amount of time than the 7 days, and they did not have any adverse events from that. We can go to the next slide. Okay. Now, in terms of dosing, 25% of the patients remained on the 300 milligram maintenance dose. And interestingly, 55% of the patients required supplemental sublingual buprenorphine at a dose range of 4 to 24 milligrams due to cravings, ongoing cravings and withdrawal. Retention, 67.5%. 30% discontinued, and 1 was lost to follow-up. So there was no difference in the proportion of patients seeking acute care. Illicit opioid negative urine drug screens was in 65% of the patients. There was no overdoses, and there was no withdrawal or precipitated withdrawal reported after the induction of extended release buprenorphine, despite some ongoing illicit opioid use.
One thing I'll just clarify, Puya, is that the idea of supplemental sublingual bupe was at any point during the study. So it doesn't necessarily mean they needed it on an ongoing basis, but a significant number of people at some point needed some kind of sublingual bupe. And we don't have any information from this poster about when they found they needed that, whether it was early or late, or before another injection.
Thanks for that, Baxter. Next slide. Okay, so they made a number of conclusions, but again, there's limitations with regards to this study being retrospective, small numbers, etc. But from their observations, they went on to say that sublingual buprenorphine for fewer than the recommended 7 days was safe and did not result in worsened outcomes. And clinically, I found that as well. And also extended release buprenorphine, 300 milligrams monthly maintenance doses was safe from their observations. And substantial proportion of patients required supplemental sublingual buprenorphine during the first few months on extended release buprenorphine. And again, as Paxton clarified, we don't exactly know how long they required it or specifics around when and at what doses. So I think that's it for that paper. We don't have a lot of time left. Are there any questions before we move on?
I don't have any questions in my field. I do have one overall question though that I wanted to end with. Do you guys have another paper that you want to breeze through before that, or we can do
well, we have 6 minutes.
Your paper that's next, Puya. Tell us about your paper.
Well, okay, I can briefly go through it, although we don't have a lot of time left. But yeah, so this was a case report. This was actually the first patient ever to receive extended release buprenorphine in Canada. And Paxton, you want to go to the next slide? And really, the question and the challenge that was in front of us with this patient, it was a very young patient who lived under very difficult circumstances, very chaotic lifestyle, had fallen off of methadone, sublingual buprenorphine. She was induced onto sublingual buprenorphine in hospital and came off of it 3 days later and then overdosed. So we're in a situation where we wanted to use extended release buprenorphine. She had agreed to it, but we really did not have the 7 days for the induction period. Also, she would not have been able to tolerate experiencing withdrawal during the induction phase of sublingual buprenorphine. Again, given her frustration tolerance, etc. So you can go to the next slide. I'll just sort of breeze through this pretty quickly. So basically what we did here was we used a rapid sublingual buprenorphine microinduction protocol to get the patient onto buprenorphine, and then very quickly after that, so that eliminated the need for the patient to have a period of abstinence and experience opioid withdrawal, which would have caused her to leave hospital because she certainly was not certified at this point, but willing to participate in the treatment, and also shortened the induction period. And of course, minimize withdrawals. So we induced her using the protocol, went straight on to the buprenorphine induction. It was all done in 3 days. The whole induction process was seamless without any withdrawal or precipitated withdrawal or adverse effects from the buprenorphine extended release injection. I think that's it for that one. So we have 3 minutes.
3 minutes. So I have prepared questions. Other people have questions here, but I'm gonna ask each of you one question and then we'll be done. Paxton, can you tell me, because I think that each of us as clinicians need like a different tipping point for how much research is published before we change our practice. Like what for you about this literature was the thing that made you change your practice?
I mean, for me, I look at the, I guess I look at that initial trial compared to a placebo control, and I read that and I was kind of like, who cares? Like the fact that this medication works better than nothing at all is not a shock to me. So to me, you know, I haven't really seen a lot of real world data, and I'm very curious to have that data to better refine who would do better on this than and who won't do as well for it. But for me, more than anything, I think that treatment with buprenorphine, you know, there's a number of components to it, and I think for some people the ritual of it is certainly a part of it. I think, you know, for some people it may be seeing the pharmacist that's a part of it. There's definitely different things that feed into it, but for me, I think a huge part of it is just is the physiology of achieving a certain serum level. So it was never a question. This was never a question of biologic plausibility to me. I'm sure that this is a medication that can work, and the question is figuring out who it will work best in. So that's my real interest, my real question, and I don't think we have really answered that today. Except for maybe talking a little bit about the information about who to drop down and who not to drop down in. But for me, it was never really a question of can it work. It's who does it work in. So for me, I guess becoming a bit of an early adopter for this medication. I'm becoming quite a big proponent for it because in my particular clinic, retention of buprenorphine is not typically good for me. I don't retain a lot of patients, and a lot of times it is about the hassle of even if it is an easy medication to weekly dispense. That I hope that especially for people who are working, who are tired of the medication, who are tired of going to the pharmacy even semi-regularly, that this is a way around that. So for me, it's more around the biologic plausibility that led me to prescribe this, and I am looking forward to more data to really refine who I think will respond better to it. But in the end, it's going to be an individual discussion with a patient every time as to whether they think this would be better for them or not.
Well, it's a good lead in. My final question for Puya is, what do you want to see published over the next few years about this medication?
Yeah, just going on what Paxton said, just studies in real life patient populations around, you know, patients that use a population that may be using primarily fentanyl analogs, and also patients who are living under sort of psychosocial circumstances that are similar to our patients. I think and beyond that, again, more around the difference between maintenance on 300 versus 100, efficacy, etc. I think those two factors would change my practice. So looking forward to that if it happens.
Great. Okay. Well, maybe we'll reconvene when some more papers are published and chat through them. So we're out of time, and thank you so much to all.
Awesome. Thanks, Christy. Thanks everyone for attending.
Thank you so much.